There's no slide. Oh, well, welcome. A new format we're starting today. It's an impact chat that we're having. And it's a little bit different. We're in a format here and gathered and we're thankful for being here. One of the things that I do need to do is grab my notes because we don't have those up there. So this is part of the technology that we're hitting here today and trying this new format. There we go. Welcome now to the future inspired by you. I'm your host, Tim Fagan. Glad to be here today. I'm a member of the Helen DeVos Children's Hospital Foundation Board and part of the executive committee for Spectrum Health. And we'd like to thank you today for joining us. As you can see in this new impact chat, we help to be a little bit more informal, be able to ask some questions. And we're joined by leaders both in the clinical area and at Spectrum. And what we're talking about today is, I think you're going to find very fascinating. It's fixing hearts remotely using robotics. And today I'm joined by Dr. Penny Wilton. Penny, welcome.
Hi.
And Dr. Ryan Mader.
Thank
Ryan,
you, Tim.
Glad to be here. Penny is the VP and Department Chief of Cardiovascular Health at Spectrum Health. She also is the endowed chair for the Frederick Meyer Heart and Vascular Institute. Ryan is section chief for
Interventional.
So that means you're coming inside.
And they're working, yes.
Interventional cardiology at Spectrum and is also the medical director of the cath lab.
Mm-hmm.
For those watching, this is going to be your chance to use the live chat stream, and we ask you to participate in this conversation today. So you're able to ask questions, come on there and do some chats. But I guess today, Penny, we'll start with you. And if you could give us basically an overview of the program, that would be great. And we'll let you take it away.
Thank you. Thanks so much, Tim. I'm just so excited to be here today to share with you about what's going on at the Frederick Meyer Heart and Vascular Institute. Really over the last decade and 15 years, the programs that we have at the Meyer Heart Center have really grown in terms of volume, capability. Patients no longer have to travel to the Cleveland Clinic. We just have the expertise locally. So we're going to be sharing some great, exciting stuff that Dr. Mader's leading in our discussion today. When we look at all of our programs, we do everything from prevention to transplantation. And I'm excited to share with everyone today, like our transplant programs are celebrating their 10-year anniversary, and our lung transplant program is ranked in the United States in the top 4, probably about out of 130 programs in terms of quality for 1 and 3 year survival. So
it's been that long, 10 years? Wow.
So, what we're going to talk about today is some sort of really niche programs that rely on technology, really exciting stuff that Ryan's leading. But, what we are providing to the community in West Michigan and beyond, our patients no longer need to travel to the east side of the state or to the Cleveland Clinic. We offer very advanced capabilities right on our doorstep in West Michigan. I was actually going to share a patient story, if that's okay,
That
Tim.
would be great. I would love to hear.
Yep. This is, I think, always when we talk about what we're doing in medicine, if we bring it back to the patient, and we have this wonderful story of this patient who presented with a heart attack at Holland Hospital at the beginning of the pandemic, sort of well into last year. She arrived at the hospital in a critical condition. One of our specialists in Grand Rapids had to race over in the middle of the night, one of the cardiologists, to assist the cardiologist at Holland Hospital, sort of threading a little heart pump through the arteries to help this patient survive through the night. We got her to Grand Rapids. She'd suffered a myocardial infarction, which is a big heart attack. She was in shock. She needed emergent open heart surgery because she had a rupture of her papillary muscle, which is a life-threatening, often fatal condition. And she presented, she was COVID positive, so she had very nasty complications with her lungs. She was in ICU for a very long time, sort of during the middle of the surge of the pandemic. So we had extra ICUs opened up. She had a trach, she had dialysis. And here she was, I think, you know, she's the grandmother of something like 8 grandkids and her husband by the bed. And I'm just so excited, you know, through our seamless care, teamwork, expertise, like, you know, Ryan's partners took care of her. She walked out of the hospital. And I think this is a testament to the people, the expertise, the technology, and the coordination of care that we were able to pull together right in the middle of the pandemic. So it's a great story.
Our next question, Penny, is also for you. And maybe you can tell us a little bit about how philanthropy plays a role with the Institute.
Sure. And, you know, Tim, philanthropy is really important. It really helps underpin us delivering on our vision. And our vision for the Meyer Heart Center is actually based on something called Lena Meyer's 3-legged stool. So the 3 legs of the stool are clinical excellence, where we aspire to high quality outcomes, you know, being ranked top decile in the country. The second leg is research, and Ryan's going to be talking about his research today. And then the third is education of our next generations of doctors, but also how do we educate the community about heart disease? If we want to give a few more sort of examples, coming first of all to education, philanthropy helped us build the Lois Mole Simulation Center, which is an excellent place for our fellows to learn how to do catheter-based technologies like Dr. Mader's team do. So we have a whole mannequin simulation set up down there so they can practice on that, so then they can become very agile and accomplished and expert to take care of a patient like the story I just shared. Philanthropy's also funded our fellowship programs. So we're in our 5th year of putting forth a number of fellowship programs in cardiology. We have a fellowship program in cardiac surgery and vascular. So this allows us to train the next generation of doctors and really raises the game for us at the Meyer Heart Center. The other theme that we're really going to focus on today is robotics. And, you know, robotics, minimally invasive, all this technology really drives our treatments these days. So we use robots in the operating theaters or operating rooms with the cardiac surgeons. We have a very strong robotic heart surgery program for mitral valve disease and also for lung cancer work. Dr. Lamb and his team have done published a big series of all the lung resections they've done using the robot. And then really today, what we're going to talk about is the work Dr. Mader leads in terms of robotic heart catheterizations, which truly is going to revolutionize how we take care of patients with coronary artery disease.
Well, we're excited to hear from Ryan and about the background and research, but I saw the short video clip that we're going to share here, and I think people are going to find it to be very, very exciting. So if we could just take a moment here and show the video clip, that would be great.
I felt a pain that I had never felt before in my chest. And the last thing I actually remember is telling my husband, this is a sign of a heart attack.
We have an issue right now where patients who suddenly develop heart attack symptoms and have a closed artery, they can't get to a hospital capable of opening up that artery in time before permanent damage is done.
To know that I just got lucky by where I was when my incident happened, it's a little sobering.
And it occurred to us that if we can do these successfully sitting, 5 to 7 feet away from the patient, why can't we do this over longer distances? Any physician anywhere in the United States could reach almost any other hospital.
For people like me who might not have access to their doctor that they trust and they've formed a bond with. It's just amazing.
Wow. It's just incredible. So tell us more about the research and how you got started down this path. I'm looking at this, it looks like science fiction to me, and it's happening today. So tell us a little bit more, Ryan.
Yeah, so we recognized, years ago that we have a problem, not just in third world countries where healthcare, may not be as available, but even in the United States and in our own backyard in West Michigan, where, we have, common problems like heart disease and heart attacks, where, particularly heart attacks, I think being a good example of this, that when a heart attack starts, that a patient needs to get very quickly to, a hospital that's capable of treating that and opening up that artery. And, we have at Spectrum Health about 13 hospitals that commonly refer their heart attack patients to us emergently. And when those patients show up at those outside hospitals, they have to travel to get to us. And often they'll come by ambulance or they'll come in a helicopter. And if the weather's good, they can usually get to us pretty quickly. But parts of the year when the weather is not so good, it can take them even up to several hours if it's in the middle of a storm to get to us. And in the midst of a heart attack, lots of bad things can happen as that time passes. And so, once the patients get to us, we can open the artery up. But I think, we have technology now that might allow us to actually, fix those patients without the need for them to travel to us, which I think really could potentially save lives.
Is this in the research phase then we're doing this, or when will this become real? I saw the video of distance. Is this taking place right now or going to be?
So where we are now with this, we started the first research project in this anywhere in the world 7 years ago in 2014. We did a small pilot study which the foundation helped fund, where we started exploring whether we could use the robotic system to fix the arteries of living patients who are in our cath lab, with me as the physician sitting in an adjacent cath lab. And so that was part of a research study. All the participants agreed to take place in it. And we demonstrated really for the first time that, using modern robotic technology, you don't have to be, as a physician, in the same room as the patient in order to fix their heart. And so that study was completed and published eventually. And that was really the first study, in the heart, showing that you can fix a person's heart from a distance. And the distance in that study was only 55 feet. We say only 55 feet when every heart surgery prior to that had always been, right next to the patient. But we then, again, with the support of the foundation, were able to do additional research studies where we demonstrated that we could actually do this from a distance as far as 100 miles away without any issues. Though that study was not done on patients, but we showed that it was technically feasible to do that. And then using the research that we had done right here at Spectrum Health in Grand Rapids in 2018, one of my colleagues in India actually did the first patients from a distance of about 20 miles away. And so they used all of the setup that we had demonstrated works here in Michigan, and they took that setup, applied it to a center in India, and demonstrated that you can successfully fix patients' hearts from about 20 miles away.
So I'm just thinking of the Spectrum system and the way we're structured, so that somebody in Reed City, let's say, comes into the facility in the future, you could perceive that person having emergency care basically virtually.
Yes, I think the research that we've done has shown that is technically possible right now using the technology that we have available. I think at this phase, we're really trying to work out logistically how to make it happen. And I think Reed City is a good example because, I can think of a couple of years ago, a case in the middle of winter of a young woman that suffered a heart attack, presented to Reed City. And because the weather was bad, it was the middle of a winter storm, it took her 3 hours to get down to us. And I'm confident that that patient's outcome would have been significantly better had we been able to use robotics and telecommunications just to fix her while she was, shortly after she presented to Reed City, and eliminated the need for transfer.
So is this type of long distance procedure risk-free, or what are the hurdles that research has to go
Yep.
through?
So there are a lot of questions we're still trying to answer. One of the things that we have been interested in recently is how much does distance impact our ability to do these remote robotic procedures? Is there some distance that would be too great for us to actually fix somebody's heart, from a distance? And the answer to that, we think, probably is no. And that's really the research that was the center focus of that documentary. Was a project that we had done where we partnered with Verizon Wireless. We partnered with Corindus, the robotics company, and actually flew to a Verizon lab in Boston, sat down at robotic controls, and showed that we could drive a robotic system and potentially fix somebody's heart. And that robotic system was in New York City, so a little over 200 miles away. The robot performed as it would as though I were sitting in the room with the person. And then we replicated that same thing where I was again sitting in Boston, and we had a robotic arm in San Francisco. And, it's roughly a distance of about 3,000 driving miles. And even over that great a distance transcontinentally, we had no issues with the signal transmission using modern internet. And we did that. We replicated that research over wireless technology, 5G wireless networks. We also did that same thing just over commodity, kind of commercially available internet, showing that it is technically feasible to control a robot from one side of the country to the other.
So what time frame are we looking at for, do you think, this turning from research into something that we might even see here in West Michigan?
I think there's an excellent chance that we will begin in-human studies in the United States within a fairly short time frame.
We were telling a story beforehand. I mean, when I grew up, my father had bypass surgery. I grew up in Midland, Michigan. And at that point in time, you had to go all the way to Cleveland to get just a simple bypass. And it was being gone for several weeks. And now, certainly, you can go to a Reed City or to a satellite area if this technology goes. And it's really amazing technology.
Yeah, and I think that's a good point. And, thinking about, when your father had to travel to Cleveland for heart care, I'm certain it probably created a burden for you and your family, not being able to make that travel, or perhaps making that travel, but, having, expenses and other things that may have been challenging. And, we see that with our patients in West Michigan all the time. It's hard for families often to travel to Grand Rapids, to see their loved one get care and provide the level of support that they want to provide their family member. And, I think this remote robotic technology may allow us to overcome that in the future.
And Penny, this all ties back into your legs of your stool. How? What do you see this fitting into kind of the bigger picture of what the Institute's doing and where it works together?
Well, I think, our vision to be, at the forefront, pioneering cutting edge research, Ryan is really a great example of a bright physician who's able to think outside the box about how technology can bring, treatments that are available to patients if they live close by. But now, if you live miles from Grand Rapids, or, my mind's just thinking, what global impact would this have on third world countries even, or rural Australia where I once grew up? I mean, it's just mind-boggling, because you may not need a cardiologist in rural Australia or Africa. You could have the robot, the technology, a technician, and then an expert like Ryan working the console miles away. I mean, it's truly revolutionary. It's going to change how we set up hospitals and practice medicine.
It's hard for us to imagine. I mean, we've had really generous folks here in West Michigan, and philanthropy has allowed us to be really, Ryan, this is nationwide news was making on this. I think it was, publicized out there, and you're part of that program. And I think that we're all just really blessed in West Michigan to have the philanthropy to support this. We also are asking for anybody who has questions to certainly give us some questions that you can answer regarding this and changes that are taking place. But the future, as far as other areas that you see taking place in, we've gone to transplant now, it's been 10 years. This is in the future that's taking place with it. The care and the doctors here in West Michigan, and it's all under that quality umbrella, right, Penny?
Correct. To answer your question, about where's this going to go in the next 10 years, I think more and more minimally invasive surgery, more robotics, more very complex imaging that drives a robot's arms, like for a tumor. So it's going to be very interesting to see the intersection of computers with imaging and robotics, what the role of the physician is going to change, I think somewhat in these procedural areas. But at the end of the day, if we just continue to focus on top decile quality, innovation, technology, hiring the right people, I think, the Heart and Vascular Institute is going to really be a game changer for cardiology, particularly in Ryan's field.
Yeah, and if I could just comment on that too, Penny, the role of physician changing, I think is really important thing to think about. And when we think about heart procedures and just using coronary stenting as an example to treat heart attacks, let's say, the average interventional cardiologist in the United States, performs that procedure only about 50 times a year. And, we're lucky, at Spectrum Health that we have very high volume operators that do that procedure many more times than 50 a year. But when you think about half of the interventionalists in the United States doing that less than 50 times a year, we start to worry about, quality issues at some smaller centers. And to Penny's point, I think that, we have the ability now with these technologies to use robotic systems, to use artificial intelligence to create the ways that we could improve the procedural skills that those physicians have at their fingertips, and to make these procedures more automated as driven by a robot. And I think a good example of that we all experience when we travel is in the flight industry. When you get on an airplane, my understanding is pilots do the takeoff and landing, but the computers fly everything in between. And that has made aviation in the United States and around the world much safer. And I think the same, potential exists for, robotics in surgery and in cardiology. And so, we've actually begun using the simulation center at Spectrum to study the ability to do robotic procedures partly automated. And that's, again, I think a nice example of where the foundation has really supported the work that we do to push this field to try to improve safety for patients, not just in West Michigan, but around the world.
So a question, we have bypass surgery and we have stents, and how do you determine how invasive and what's going to get the best results when it comes to heart?
Yeah, so it's a complex question. Generally speaking, if it's one blockage in somebody's heart, we typically will fix that with a stent. If it's blockages kind of everywhere in the heart, then we typically will refer those patients to bypass surgery. Different medical conditions that patients may have will change kind of what we do. So, diabetes or lung disease may drive us in one direction or another for how that gets treated. And I think one of the benefits that we have at Spectrum is our heart team approach, where, I think still a lot of hospitals around the United States, it's one physician or two physicians that make the decision on, what a patient gets. And we're very fortunate at Spectrum to have a heart team approach where we will convene once a week for more complex cases. And we have 20 physicians providing input, heart specialists providing input on what the best treatment is for any given patient. And I think it's something that we found that the patients and their families really love, that this is not just one person making these complex decisions, but a team of teams.
Okay. So, Penny, what are you seeing come in? There's certainly a wide variety, but what are you seeing as far as cases that are coming in, patient diagnosis that come into the Heart Center?
So that's a great question. And I think the last year, I'd say COVID changed things a bit. We had a lot more admissions from COVID. Interestingly,
A lot more admissions from COVID.
yes,
Really?
you know, our hospital was full of
Right, yep,
COVID, but
yep.
interestingly, in cardiovascular, we had patients presenting very late with heart attacks because they were fearful of coming into the hospital. So, you know, Ryan and his team would often have patients who were sitting at home for days with chest pain and then presenting very late with complications of heart attacks that are quite severe. You know, you can end up with sort of like death of the heart muscle and end up with holes in the heart because of the myocardial infarction. But prior to COVID, the most common diagnosis that we see for admission to the Maya Heart Center is heart failure. And heart failure is a lethal condition. It's, you know, killing over 6 million Americans every year. Obviously, we treat the whole range of heart failure, from trying to prevent heart failure by reducing your salt intake to medical management, blood pressure management, and then all the way to left ventricular assist devices and heart transplant. But it's a big disease. It kills millions of Americans. Largely, it's preventable by lifestyle factors, good blood pressure management, and avoidance of certain risky behaviors that can increase your chances of getting heart failure. Ryan, do you want to make any comments about how dangerous it is to stay at home if you're having a heart attack and what we saw during the pandemic?
Yeah, very dangerous to stay home with a heart attack. And you know, at any given year at Spectrum, we would typically see about 4 to 5% of our patients will have heart attack onset and then present, you know, more than 12 hours later. So they would sit at home for at least 12 hours. And so again, if you look back historically at our center, only about 4 to 5% of patients will wait that long. Early in the first couple of months of COVID, we were seeing about 20% of our heart attack patients waiting more than 12 hours from their chest pain onset before they came in. And as Penny had mentioned, we saw these, you know, a number of very late complications. And so nowadays, because treatment of heart attacks has gotten so good and so efficient, you know, there are certain complications of heart attacks that we just don't see because patients get treated very quickly. And so these complications where people are developing holes in their heart or things are rupturing in their heart from late presentations of heart attacks, we'd maybe see 1 to 2 of those a year. And we saw within the first couple of months of COVID, 5 of those consecutively, which is incredibly unusual for us to see. And again, it's a manifestation of people trying to sit at home and not come in and seek
Okay, I'm
care.
going to have to take one moment here as a layman again. So everyone says you'll know when you have a heart attack. Do you know when you're having a heart attack? Better safe than sorry. Do you come in early? What is the chest pain or what are the symptoms like? This is,
Yeah.
you know, I assume I will know if I had one.
Yeah, you know, not everybody has chest pain. And so some people, I think, you know, misinterpret their symptoms for other things. But the most common symptoms that we see are that people will have chest pain or pressure or aching or squeezing, you know, some sort of sensation in the chest. It doesn't necessarily need to be severe. It can even be a mild sensation. Commonly, that discomfort will radiate or move up into the neck or into the arms, the left arm being more common. People will get nauseated or sweaty very commonly or feel short of breath. But what I tell my patients, if you feel anything in the chest region that feels abnormal to you, that it's not something that you typically feel, you need to seek medical attention right away. And I often say use common sense. If it doesn't feel right, don't ignore it. You know, come in and let us sort that out.
That's great advice. So, Penny, a little bit about the program, the transition from heart surgery. Maybe you can kind of take us through a little bit about
how to get back home,
yes,
live
I
a
mean,
healthy life.
it certainly is, you know, a traumatic life event, which
Sure.
we've seen. How do we help to get as patients back into a full lifestyle again?
So, you know, the care and the treatment doesn't stop after the procedures that Ryan's performed in the cath lab or our surgeons have performed in the OR. There's a whole care plan to organize around the patient's discharge to get them back home, including, you know, education about their medications, changing, you know, lifestyle factors, getting more exercise. we have a very sort of special cardiac rehab program to get patients exercising with monitoring safely under sort of supervision, so they can sort of progress towards, you know, where they're free to walk back at home, and you know, dietary advice. And then, you know, for the sicker patients, like the patient we discussed earlier, there's a whole community of care, if you like, with physical therapy, visiting nurses. So we really wrap around the patient, and each patient would have a bespoke plan based on their needs and whatever really needs to be focused on. So, and we follow up, you know, with remote video visits or in-person visits with our cardiologists and surgeons. So making sure they're being monitored and tracked after their life-saving procedure.
So, the symptoms of a heart attack we talked a little bit about, are they different between men and women, or the same as you described before?
Yeah, they can be different. So, you know, the symptoms that I described before are very characteristic of what men will feel with heart attacks. And some women feel the same thing, but it's been well documented that women can have atypical symptoms of heart attacks. And so their pain or their symptoms that they have, you know, aren't necessarily always the same as those that I described. And so again, I think that if, you know, for the women out there in the audience, you know, anything that they feel that, you know, in the chest, upper part of the abdomen, neck, that they are uncertain what it represents, and it makes them uncomfortable, they really need to seek medical attention.
Got it. And Penny, are there differences in socioeconomic status and heart disease in our community here in West Michigan? Are you seeing some trends with that?
Yes, you know, I think there's been a lot of conversations nationally in the last year about healthcare disparities throughout the United States, and there's absolutely no doubt that you know, people that live in a sort of situation where they have a lower income or education, or there's psychosocial factors, those play a big role. You know, we talk about the social determinants of healthcare. So, you know, whether you live in a food desert or your family are exposed to food poverty and you can't eat the healthy foods that you need to take care of your heart, you know, whether you have transportation and you can make it to appointments, whether you have the income to pay some of the co-pays for some of the medications that one needs to take, all of these factors play a significant role in how, you know, someone manages their heart disease. Ryan, did you want to add any sort of points about social disparities?
Yeah, I mean, one of the social disparities that I'm particularly interested in is geographic disparities. And so there are certainly pockets in Michigan and around the United States where they're more rural locations and they just don't have access to care. And that's where I'm hopeful that this research that we've been working on with using, you know, telerobotics and telecommunications will allow us to eliminate some of these geographic disparities that exist, and really, you know, offer the same level of care to patients regardless of where they live and how close they are to us.
Yeah, well, you've given us a great glimpse of the future of what we're doing here today. And I just really want to thank you both for being here. You know, it's this chat format is new, and hopefully it's been engaging for the folks out there. One of the things that we want to do in concluding is to talk also, we're going to have another impact chat, which will be taking place on April 15th, which the topic is going to be talking about the parallel pandemic, and that is mental health crisis facing today's youth. And they'll be discussing not only the physical health of our youth in the community, but also the mental health. So again, we would like to thank the donors and the community for their generosity. And it's just exciting to see, Ryan, some of the research and things that we can look for in the future due to, frankly, the generosity of the people here in West Michigan. So thank you both for being here, and appreciate it, and have a great day.
Thank you.